Happy that everybody's here. This is the Direct Primary Care Coalition Steering Committee meeting and fly-in. We're also super excited to have Hint Health with us today, hosting us virtually with a live stream of this event as well. And Haley, are we up and running? Awesome. So welcome to everybody who's out there virtually as well. I'm going to kick it off to Garrison Bliss, the founder of the Direct Primary Care Coalition, to say a few words. And then I thought what we would do is just go around the room, everybody introduce themselves, and please, particularly for the physicians that are in the room, spend a little time talking about what's going on in your practice. If you're new to the group, what led you to this group and what led you to DPC would be awesome. And we'll go from there and get it all started. And then as soon as Garrison, makes some introductions, we'll run through the agenda and start talking. We are expecting Representative Earl Blumenauer from Democrat from Oregon, who is the lead sponsor on HR 3029, the Primary Care Enhancement Act, one of the bills we're here to lobby on this week. So with that, I'll leave it to Garrison to open up, and then we'll go around the room.
Thank you. Thank you, Jay. I don't have a lot to say. And the reason we brought you all here is because I want to hear what you have to say for the most part. It's probably not a secret that I was the first person to actually call himself a direct primary care doctor. There's some discussion about who actually started this thing originally, but I'm quite happy to be in that position. And I've been watching this thing grow. I feel like I've seen my children and now my grandchildren. And I'm really proud of all of them. This has been an amazing trip for me, and I think for the country, to see what's possible in primary care. One of the things about this is that we innovate in ways that the rest of the healthcare system seems incapable of innovating. And a lot of the people who do that innovation are here, but they're thousands of them out there as well, and hopefully some of them are going to be watching what we're up to. We are playing this in Washington, D.C., which is itself a tough place to do anything reasonable and to get anything done. But it's also, this is the peak of Mount Everest, and if we're going to climb it, we're going to have to go through this part of it as well. I am looking forward to what you folks have to say, and I just as soon get on with that as soon as we can here. So what I'd like to do is to go around the room and have each of you introduce yourselves and tell us a little bit about what you've done in the last year, or what insights you have to share with the rest of us. And we'll just make our way around the room, and by the time we get back here, then we'll be ready for the dog and pony show we've got to put together for you. So I think since we went right to left, let me just keep going left.
Okay, thank you, Garrison. I'm Pat Tokars, and good to see many of you back again. In the 70s, I was a health policy geek who studied what was wrong with healthcare and thought, I'd dedicate my life to making this healthcare system work. And luckily, someone came along who actually did it. But over the last couple of years, I've just been amazed at what having membership medicine, where it allows physicians to actually work directly for the patient and cut out everything, all the noise in between, has been transformative, going back to the way it was, quite frankly, when I was a child and had my own family doctor. Since stopped seeing patients after 45 years, over the last several years, I've been working with Michael Fine, trying to create another movement called Primary Care for All Americans. And many of you know that and support it. But if you haven't heard of it, come get a card. There's a QR code and you can find out all about it, or just Google Primary Care for All Americans. And we look forward to working with you on the next chapter of getting all the local communities to say, this primary care thing, we should make it available to all our citizens. That's our goal.
Great. Hi, everybody. My name is Ben Aiken. I'm a family doctor in Asheville, North Carolina. I have been in the direct primary care model for 6.5 years now. The first 2 years were as part of a fully integrated health system, which is pretty atypical start to DPC, and then transitioned out of the health system when HCA took over the health system. And have been in the independent capacity for the last 4 years. We have 2 locations at this point. There are 8 physicians on the team, and we have one of those docs does a very part-time on-site role for a business that we support. So we're about 50% employer and 50% retail. And through that work with employers over the last 4 years have developed some understanding in that space, and also work for in essence, a startup insurance company called Decent, and serve in the head of direct primary care role for them, and trying to build out their, in essence, kind of contingents or network of direct primary care, because they build direct primary care into the center of all the plans that they're offering. So really excited about the traction that they are getting, or we are getting on the Decent side, as we've been in market now for the last several months, and really excited about the Rosetta Fest that will follow this. And speaking mostly on that side of things. So really excited to be here. Have been involved with the steering committee really since the role with Decent started a couple years back. But really excited about the traction that we're seeing in the last 6 months, and the conversations that are going to happen today and tomorrow.
I'm Haley. I'm on the marketing team at Hint, running our live stream for this meeting today. And in addition to working for Hint, I'm a DPCC patient, and my doctor is here today, Dr. Rhoda. It's awesome. Yeah.
I'm Margaret Policy. I know many of you from a couple years ago, but I've rejoined the Direct Primary Care Coalition this fall as our Health Law Fellow, and have been working hard to get everything today happening, and doing some work where it's needed. So if you have any ideas about, anything that we could be implementing in the next couple of months, especially, I would love to hear them. And it's really nice to be here with all of you guys.
Bill Eskew, family physician and attorney, put the website DPC Frontier up close to 10 years ago now, which doesn't seem possible. And I work with an on-site direct primary care practice called Proactive MD based out of Greenville, South Carolina.
It's totally not representing all the things he does.
Bill's always modest.
We don't have all day.
I'm Marielle Conception, family physician out of rural Northern California, a town called Arnold. I am a fierce advocate for the independent practice of direct primary care all over this nation, and I host a podcast celebrating that. And there's almost 200 physicians who've shared their story about direct primary care in this nation, and it is such an honor to be here to help spread those stories to the people on Capitol Hill. I came in February with some of my colleagues, so I'm so excited to be back.
Mariel, how do people find the podcast?
Yeah.
Here.
So mydpcstory.com, the podcast is called My DPC Story. And if you just Google DPC podcast, it'll always come up in whatever browser or podcast search you're looking at.
It's a very popular podcast, and it will make you laugh, cry, and change your life. Not kidding.
I'm Janine Rodos. I'm a family physician in Santa Cruz, California. We've been in DPC, we're in our 9th year right now. We've just expanded to another position. I'm looking actually to do further expansion because we're crowded in our space right now. We've been working through almost 200 patient list of people wanting to come into practice. So we have a lot of kind of fervor in our community that we've seen over this last couple of years, actually, with growth and movement. So I'm here actually with Marielle because we're trying it at the state level with some of the organizations. I'm part of the local medical society, so the CMA, and then we've been working with CAFP to sort of be a foothold and a presence at the state level for the direct primary care movement.
Mike Rosenthal, Senior Vice President of Business Development with ProAssurance. We're one of the country's leading medical malpractice insurance carriers.
All right, I'm Mallory Early. I'm the Director of Risk Management with Pro Assurance and here to help hopefully form a partnership with you guys and see how we can help your individual practices from a risk management standpoint.
I'm Seth Swanson, I'm the AVP of Business Development in the Southern Region for Pro. Special thanks to Margaret for helping us get here and giving us all this information. It's not easy to put one of these on as we've done little things throughout our year, but we're excited about this opportunity and look forward to working with everybody here in the coalition.
Great. I am Malo. I am from Sigma MD. I've just arrived from Brazil. I have a long history in the healthcare system. I was part of a founding team of a practice focused on diabetes treatment in Mexico. Then Sigma MD found me, and I have been working for the company since then. And basically, I'm a big fan of direct primary care. So we have been developing EMR, all-in-one platform tailored for direct care physicians. And we are here to support the movement as we can.
Thank you for being here. All of you. Appreciate it.
Morning, I'm Matt Hayden. I'm a family doc right here in the DC metro area. Recently moved into new office space down in Arlington, so I was in Alexandria. Airport. Place.
He does a good job of keeping me out of his office. So I'm been to the new office. It is my family doc.
Things are change and adaptation, and we're using the extra space to or some other physicians who want to start a practice, and it's tough to lose and then use the space to get things going. We've got some children care practitioners, just getting some complimentary services in there.
Hey, everybody. I'm Dr. Clint Flanagan, family medicine physician, been in practice for over 20 years. Been part of the Direct Primary Care Coalition Steering Committee since it was Garrison and myself and Rashika and maybe Vic Wood and a few others. So it's been a minute. This is our 15th year at our company. Our company is called NextEra Healthcare. We have we started with one location in the Boulder, Colorado area, and now we've got about 200 some locations across 22 states, and continue to grow, mainly servicing employers, but we also service individuals and families. I have about 700 some members myself, so still practicing for the time being, and having a lot of fun doing so. I echo a lot of Garrison's statements. It's just awesome to see where this has all come, because years ago we were, throwing spaghetti at the wall, hoping it would stick, and sure enough, it has. I guess our newest announcement is you'll hear it just came across the wire today. So there's some friends and colleagues in Chicago that do direct primary care, Dr. Alex Lickerman, and they've partnered up with NextEra Healthcare. So now we've got 5 locations in Chicago, courtesy of Dr. Lickerman and Rita. So we're having a lot of fun and appreciate being able to get back face to face here in DC.
Hey everyone, Haley Hodgkins. I joined the team at NextEra Healthcare about 6 months ago. About 6 months ago. My title is CXO, so I'm sort of like a chief of staff, helping the NextEra team on all sorts of growth. Expand geographically, bring on more docs. So that's lots of fun. Hi, I'm Michelle Nevlet. It's good to see you all again. I'm one of the lobbyists for the Boeing company. Boeing has been involved, as you know, in primary care and focused on primary care for many years. We did our first DPC with Iowa back in 2018. Since then, I've worked on medical. Actually, this summer, our health benefits team has been very busy. We announced a new arrangement in St. Louis for our folks there in Missouri. And then just actually on Sunday, we came to a tentative agreement with our largest union in Washington State and Portland, Oregon. And as part of that agreement, they will get DPC free access to primary care to the partners there should the agreement get signed. So we got a little road yet on that, but the intention is to move forward with the union population, the non-union population this year. And then we're part of an RFP in San Antonio at the end of July, so we're moving into San Antonio. So there's a lot of progress here from the market standpoint, but my job is to advocate for the Primary Care Enhancement Act. And Jay and you all have been a fantastic partner in that. Thank you for all your efforts. I feel like it's closer than ever. And if we can just will it to happen by the end of the year, that would be fantastic. But we're still at it as our top health.
We're always super excited to have you. And for the folks who are new to the room, Boeing has been an incredible advocate on this. I mean, going way back. I think the first data we have that really proves concept for direct primary care came out of Boeing in 2008, I believe, that we've consistently been able to show over the years. Michelle, again, being modest, has also been our key ringleader with the entire employer community in Washington, D.C. in the Business Government Relations Committee, which is, I think, fairly unified behind direct primary care as a way to move forward. And so it's exciting to have such a leader joining us, because not only is this bringing the power of one of the largest companies in the world that believes in DPC, it's Boeing is helping us bring the entire power of the employer community to bear to help us move forward with this great model. So I can't thank you enough for being here and all that you've done for the movement. And we're just doing around the room. Welcome. We just talked about Missouri, Texas, so let's go to Oklahoma.
Jonathan Bushman in Oklahoma.
Keep going. A little bit more, a little deeper.
Also about what
Peel the onion back a little bit more. There's a little bit more to Dr. Jonathan Bushman than meets the eye.
Have 3 pieces in DPC, so I'm a DPC clinician, 6 years. Run MSO, we have 3 other clinics that we operate for. And then help with other. And just happened to look up for DPC yesterday on our plane, and that makes sense. Senator Langford and Senator Mullen from Oklahoma were just right there. So my politicking is done already.
You've already got them on the bill. Well, they might have been there before, but that's okay.
They were already there, but Senator Langford was very, very, very well versed in this.
Yes.
He was really interested. We'll be with him again tomorrow, but he wants to follow up at the end of the week to see what his next step should be to represent.
Yes, go to Senator McConnell and make sure it's in the year-end package. Did I get that right, Michelle? Hey, make sure there is a year-end package.
That was good. I didn't bother him too much. We talked.
Grassroots politics.
I am Sarah Pastor, family physician. And part-time DPC clinician and full-time head of primary care advancement at Elation Health, which so as part of my work with Elation, my role is a lot of thought leadership.
Hi, my name is Ben White. I'm from Austin, Texas. I'm with Rich and Park Mill Insurance. Bridge. I've spent nearly 20 years focusing on medical technology, and here to talk about that a little bit later. Finishing up two things with Garrison and Jay, and it's a pleasure to be here and look forward to speaking.
Thanks for coming, guys.
Hi, Tom Hoff, VP of Sales at AS Medication Solutions. So we actually dispense prepackaged meds to a lot of different DPCs. Have been trying to be very active in this space. So I guess to answer the question, what's the most exciting thing we've done over the past year? It's worked a lot with JGs. So I think that's the answer there.
Well, we're excited, and we're going to talk a little bit more about liability issues in the room. I think you all know on the liability side, it's sort of like one of those problems that usually isn't there for DPC. So what solutions might be there? We're really interested to hear as we move forward how we might be able to leverage some of the power of DPC nationally to really create some perhaps even a new playing field in liability reform as it exists today. But we're also super excited always to be working with AS Meds in our DPC RX program. It's ongoing. We're trying to tackle the vaccine monster there. And as a patient, I can say I've never really understood why primary care ends when the doctor prescribes the medication to you and then makes you go to the pharmacy to pick it up. Sometimes you can, sometimes you can't. So getting that in-house dispensing and clinic dispensing going is a big part of what we're trying to do. And DPC, provides a vehicle to allow physicians time to do that sort of thing. So we're really excited to have you guys as our dance partners here. So, and I'm sorry I interrupted, but before the rest of the team could weigh in here.
I recently just started AS Med business development liaison. I'm really excited to be here. It's my first business trip for my third week. So I'm really excited to hear and listen and learn. And yeah, thanks for having me. My name is Victoria Stanley. I am over the sales and marketing teams with AS Medication Solutions. I've been with the company for almost 2 years, and prior to that, I was in my journey into healthcare looks a little bit different than most sitting around the table. I started sitting with psych patients when I was in undergrad and finished my master's and worked my way up in the hospital, the acute care hospital. After that, swallowed up 47 of the local private practice clinics. And my job at the end of the 10 years that I was there was to oversee those. That oversight became less managing the practice and making sure the lights stayed on and more about how the physicians what to do. So I left, and my first week at AS Meds, I actually talked with Jay Keese and Brett, and my heart immediately felt just connected, So I'm not a clinician, not certainly on that side of it, but even on the other side of what healthcare and the intricacies that are tied up into that, my heart is 100% behind this movement to honor breastfeeding as a company to be at this table and be included in these conversations.
Thanks for your passion is well felt and understood.
Good morning, everybody. I'm Dave Pinker. I'm the President and Chief Commercial Officer at Kent Health. We're very proud to be sponsors of this event and very proud to support you all in this journey. For those of you who don't know us, we're a leading provider of software to DPC clinics around the country. We serve around 4,000 providers at 3,000 clinics. Our primary product is billing and enrollment, but we rolled out an EMR over the last couple of years. We've been optimizing that for direct pay practices, and it's actually going very, very well. We're also in year 2 of developing what may be a national DPC network that can be marketed to employers and others. So we're now live with that in 42 states with about 600 practices. And we're in the middle of a very, very busy season right now talking with employers who seem to be very, very interested in providing DPC as an employee benefit. So we're in the middle of a pretty exciting learning curve about what it means to be a DPC network and how we make things easier on the DPC industry to connect with employers who want to provide this to their employees. I joined the company about 7 months ago, but I've been in the U.S. healthcare industry for 30 years, both on the provider side. I actually ran an insurance company for many years. I've also run software companies focused on healthcare, so pretty broad background. And again, we're just really happy to be here and happy to support this really important
Hint has been a great partner of the coalition since almost day one. So we're super happy to have you here. You guys have been, tremendous in terms of helping us network and get the word out and providing the medium of communication with you. We also run our membership platform on Hint. So it's nice to see we're able to use some of the software that the docs are able to use to help, keep the trains running on the coalition.
I guess I'm finishing up.
You are.
I'm Mark Tomsula, family physician, prior founder and CEO of a company called Keese out of Colorado, acquired by One Medical and then acquired by Amazon. Currently, I'm the head of direct primary care strategy for Amazon Healthcare. Probably talk a lot about that, but
keep it rolling a little bit.
my job and my role inside of Amazon is to really help them understand the opportunity behind direct primary care, how they can fit into this industry and the community versus the other way around. I think my biggest opportunity inside of that organization is to really start changing the scope of what direct primary care can offer to the country. I was an independent practice, independently owned physician. So that's where my heart and core stands. But I do think there's a bigger opportunity in the country for direct primary care. My job is to try to help elaborate that and make sure it doesn't get too convoluted inside of a big organization where it doesn't look anything like direct primary care in the future. So that's my goal.
Good luck.
Someone has to do it.
Well, again, Amazon has been on the journey in direct primary care, for a long time, and it's not. I don't think it's a coincidence that Amazon has invested heavily in direct primary care, as they have invested in other aspects of primary care as well. You guys are working in the ACO REACH program and have other fingers in the pie, as it were. But we're super excited to have Mark as a member of the steering committee personally, and have the commitment with Amazon to help us, as Boeing is, not only as a provider of health benefits now, but as one of the largest employers who's interested in making good primary care a part of the employee benefits equation. And that's one of the reasons we're all here. We're all here not only for the DPC coalition meeting, but to be involved in the Health Rosetta experience as well. I'm going to go over the agenda a little bit, and we're going to talk about what we're going to try to accomplish here in the next couple of days. But the reason we're here at this opportune or inopportune time, depending on where all of you are in your vacation schedules and getting back to work in the fall and that sort of thing. But this has been best described as Hell Week by congressional staff. The rubber is meeting the road. The end of the fiscal year is September 30th. Congress either has to pass a budget, a continuing resolution of some sort to keep the government going, and sort of punt till sometime after the election, which is, I think, more than likely what's going to happen. But suffice to say, any deal that's going to have to be done in terms of moving legislation forward is happening in the next 3 weeks before Congress probably adjourns at the end of the fiscal year on September 30th or shuts down the government. Don't think is going to happen, but we'll be here until they figure out, that chapter. And I think the two pieces of legislation that we've been pushing hard are going to be integrally wrapped up in that story. We'll get into more of the message around what that is and where it goes. Suffice to say, we've had, as Michelle pointed out, I think a very good year, very good 2 years in this Congress, moving forward with our agenda, which is flat out to make sure that direct primary care grows and that there aren't federal government hurdles in the way of direct primary care being able to be. We'd like to sort of take the word, direct out of it and make it primary care. We believe that this is the way primary care should be delivered. And as payment models go, we've yet to find a better payment model than direct primary care, whether it's being paid for, whether the primary care is being paid for by the individual that may or may not have a high deductible health plan, that may or may not have an HSA, whether that individual is a part of an employee health benefit plan like Boeing's that's offering direct primary care as part of that benefit, or whether that individual is in Medicare or Medicaid. We have two pieces of legislation that we're going to go over. We have visits coming up from either with or visitors coming to visit us from the key sponsors of that legislation. We'll be hearing from Representative Earl Blumenauer here this morning. He's one of the lead sponsors on HR 3029, the Primary Care Enhancement Act. We'll be hearing tomorrow from Representative Kim Schreier from the Seattle, Washington area, who is just your regular old congressman, astrophysicist and pediatrician, leading the charge on the Medicaid Primary Care Enhancement Act with Representative Dan Crenshaw, who will also be visiting us, I believe, tomorrow night. Oh, Schreier's Wednesday. Tomorrow, Thursday. Tomorrow's Wednesday, and we have Crenshaw.
Today's Tuesday, yeah.
It is Tuesday. Sorry. It seems like a Monday to me, and I'm off by about a day, but thank you, Margaret, for keeping us straight on that. We will also be visiting Senator Bill Cassidy, doctor from Louisiana, gastroenterologist, liver doc, who is the ranking member of the Senate Health, Education, Labor, and Pensions Committee, and the lead sponsor on the Senate version of the Primary Care Enhancement Act. So we've got all of the lead sponsors of the bills that are moving. The good news about the Medicaid Primary Care Improvement Act is that it has come out of committee and passed the full House of Representatives. It's waiting consideration on the floor of the House. So our message this week is simple. We want everybody to have direct primary care if they can. Where it's available, we'll be talking about where it is and where we go from here. In fact, Margaret, if you want to put the next slide up, we'll look at the latest, Phil's mapper. And Phil, this might be a few months old actually, but we're taking over. You can drive coast to coast across the country, and every 15 minutes to an hour or so, bump into a primary care practice that's practicing in the direct primary care model. We're in every state, I believe, as of now, and the District of Columbia, and well over 2,000 primary care practices, and those are practices as small as Marguerite Duane's practice, which was here in Brookland in DC, and a house call practice with maybe 40, 50 patients, to Amazon One Medical that's taking care of how many lives around the country these days?
Yeah, about 2 million.
So there's been a tremendous amount of growth in the 10 plus years since Garrison and I started walking the halls of Congress, making sure it wasn't illegal to do primary care. We're going to continue with that growth. But moving forward into the schedule, we're going to go through about 2 o'clock today. We're going to hear from our friends from Ben Wise and our friends at ProAssurance, who are sponsoring our lunch today, about opportunities there might be to reduce malpractice costs, because you all do practice in this model of direct primary care, which is, famously since it started, been either free or almost free to my knowledge of lawsuits of any kind, because what we've done is we've created happy patients and happy doctors. We're not supposed to say that. Okay. So we'll talk a little bit about what opportunities there might be there. As a policy issue, I started lobbying for the American Medical Association back in, let's say, like 1996 or 7. It was med-mal all the time. Things have changed a little bit. We're in a different environment than we were then. It's still a key issue on the minds of many members of Congress, how we can reduce malpractice costs, reduce the litigiousness in our medical system today. And I think you all are going to be part of the equation there. We're going to then move on into some advocacy training and message development this afternoon. We won't spend a ton of time, but around 1 o'clock, we'll start to talk about exactly what's in those bills and how we're going to position that with the meetings that you all are going to have mostly tomorrow. There are a few meetings that some of you are probably aware of that are happening this afternoon. Margaret, I think we'll be ready at 1 o'clock. Are we ready to hand out the pairings and the tomorrow morning?
Yeah.
Okay, so we'll have an opportunity to talk about what meetings we have tomorrow. We have 25 or so meetings that we're going to pair up and do. We've got 2 key meetings this afternoon with the Senate Finance Committee that has both is interested in our Medicaid bill, would have to go through that committee, and is very interested in ideas about how to do a PMPM primary care payment in Medicare, perhaps as an alternative to MIPS and some of the fee-for-service alternatives that are out there now that were candidly designed not to work. So we'll have a good opportunity to talk with Senate Finance, Senator Wyden's staff this afternoon. And then we are going to meet with CMS. We're going to be talking to Liz Fowler, who is the head of the CMS Center for Innovation, about those very same concepts. What would happen if this Medicaid bill does pass Congress? What would CMS's role be in that? And how can DPC practitioners, even those of you that have opted out of Medicare, how can you still be involved in taking care of Medicare patients? And how can we be involved in sort of taking the evaluations that we've had on current Medicare, Medicaid programs that look like ACOs, patient-centered medical homes, other kinds of value-based care. How can DPC play a role in that? If we can play a role in that, where might we go if CMS decides to start paying for primary care in a monthly PMPM sort of a fee? These are all conversations that Democrats, Republicans, independents, everybody on Capitol Hill is interested in having, because there's such great value equation in primary care. Then this evening, starting at 7, we'll have a dinner. You're all welcome to at the Dubliner, a great little watering hole right around the corner. We'll morph that into, those of you who have staying power, a little debate watch party. So we'll have TV there in the room for you all to be able to watch the debate. We'll have some good times, some Guinness, and maybe some fish and chips. So we'll wind that up today. Then tomorrow morning, we're going to meet back here at 8:30. We're going to kick off. We'll have Amy Zhao, who is the health staffer for Representative Kim Schreier, Dr. Schreier, and Colin Yankovic, who is the health staffer for Representative Dan Crenshaw. They're the lead sponsors on our Medicaid bill, which is, as I said, passed out of the Energy and Commerce Committee and passed the full House. They'll give you tomorrow morning a little bit more of a flavor of what it looks like to talk to a staffer, what you should be expecting, and perhaps a little bit more insight on what might happen as we wade into the next 3 weeks with this year-end package that everybody's sort of expecting, whether it's a continuing resolution or some sort of a Medicare package in a lame duck session. We will then, between 9:30 and 4:30, have, like I said, roughly 25 meetings or so. Those are still kind of coming together. They came together late because Congress is literally just getting back to town this week. So we'll have a ton of meetings. Everybody will have, everybody here who's still with us tomorrow will have meetings with staffers and or members on Capitol Hill. Some of them will be follow-ups from the meetings you did before. Some of them will be de novo. We'll be talking to some of the co-sponsors that we anticipate will carry the water on these bills if they don't make it across the finish line this year into next year as well. So we're sort of laying the groundwork for what's ahead, even though we're hoping to pass these bills this year. And then we will head down to the Marriott tomorrow afternoon for the opening party at 5:15, where sometime 6:30 after votes, we'll be joined by Representative Dan Crenshaw, who will address the crowd. Dan is a great guy. He's in Texas, in Houston, Texas, member of Congress, Navy SEAL, American hero, lost his eye, unfortunately, in combat as a Navy SEAL. Dan, like you, believes that direct primary care is the way of the future and is a real advocate for us on Capitol Hill. So he'll be here to talk about not only his Medicaid bill, but the Primary Care Enhancement Act, which he's a co-sponsor of as well, trying to move forward with the HSA reforms there as we get into the final weeks of this Congress. And then finally, we have a number of featured presentations. Garrison's going to talk a little bit tomorrow with Rashika, Keith Smith, and some others. Thursday, sorry. And we will hear from Representative at 12:45 during the lunch. We'll hear from Representative Kim Schreier as well. So that's our agenda moving forward. Happy to sort of pause and take any questions about where we are. You know, if you're registered at Health Rosetta, you're welcome to all of those events. If you're registered here, you're welcome to any of ours, but that's kind of where we are right now.
Questions?
I guess just to make a comment on Health Rosetta, especially for those attending virtually, check out Health Rosetta's page on LinkedIn. You can find Livestream for free there. You can also get all 80 sessions digitally. I just know mydbcstory.com/Rosetta Fest is where you can find the link to get that. But especially for those people who are attending virtually and who weren't aware or have not purchased their tickets yet for Rosetta Fest, where to go. And for tomorrow morning, we will be meeting in the office at 8:40.
Yeah, suite 840, not in this room tomorrow morning. So 8:30, same building, 8th floor, suite 840. And 8:30, right? Great. We're going to dive deep into the federal side when Earl Blumenauer gets here, but I also wanted to take a little time, if you go to the next slide, to talk about states. And we have one of our experts with us, Phil Eskew, in state legislation. We want to sort of go over where we've been with the laws that have passed, where we think we're going. We're also starting to get into some other ancillary issues. Curious to hear from our friends on the liability side if there are state liability issues where we might be interested in weighing in. I don't think there are, but you know, we're looking at a lot of other things. Along with our friends at ASMEDS, we've been working really hard for the past 2 sessions to try to get the dispensing laws changed in Texas. So we'll dive a little bit deeper into that as well. But Phil, do you want to sort of go over where we've been and give us a snapshot of where we might be going in the next upcoming legislative session, mostly which will start in January of this upcoming year, 2025?
Sure.
And then we'll take some questions around that and talk a little bit more specifically about the Texas effort.
So we've got,
And I want to talk about California as well, so you guys weigh in when we get to that piece.
California's harder than everybody else. But we've got 33 states that either have laws or some sort of regulatory guidance in place that say it's fine to go ahead and do this. And as Jay mentioned earlier, you can drive across the entire country now and not run outside those states if you so wanted. Even in the ones that don't have legislation on the books, specifically defining DPC as outside of insurance, there are practices doing this. And for the most part, nobody's getting harassed, at least not that I'm aware of. The 2 states that have had issues there are Pennsylvania and Washington. And really, I'm not aware of any DPC practices that were actually closed in Pennsylvania over it. If you look at the history of this, you know, Garrison had to fight his battles in Washington State to get this passed. Vic Wood, who was one of the other founders of this group, in West Virginia, had to do that. Those were the first 2 states to start it. And really, the lawyer in me is going to go ahead and be blunt. They had lousy legislation back then, but it's gotten a lot better. And
There was no trust.
right.
There's no trust going on anywhere.
So when people
Yeah.
ask,
We now have a new insurance commissioner, by the way. We're going to run this again this year, I think.
run it back, get it there.
Yeah.
I happened to be at a conference several years ago. It was in Kentucky. And Kentucky recently passed their DPC legislation, and they've modeled it after Wyoming's, which has one of the best laws in the country. It's less than a page, it's very simple. And I got up and kind of pointed out how nice and clean this was compared to West Virginia's, which was a mess. Unbeknownst to me, there was a West Virginia legislator in the audience. So she goes back and fixes that a year later. So West Virginia now has good law too, but most of these states are do indeed deserve to be green because it's nice law in the books. And the ones that don't have it, there are a few that are making efforts. There have been discussions in Alaska. It seems like we've heard about it every year in Pennsylvania for a while, but nobody's contacted me from there this year. Maryland's discussed it with Jay multiple times. We've had a few people in New York talk about it, and it really didn't go very far. Minnesota's discussed it. Wisconsin has tried. I'm not aware of anything that really was pushed in Nevada or New Mexico. And Mary often talk about what they're doing in California. They've got a different barrier there. Most states are just worried about sort of specifying why you're not insurance, giving DPC docs guidance so that they don't promise something they shouldn't in a contract. In California, you've got a different animal called Knox Key that they're also trying to navigate. So it's a little more nuanced.
You guys want to talk a little bit about the effort with the DPC California coalition that we've recently put together and where things are rolling there? I mean, that's we always refer to that as poking the bear. We're not poking the bear yet, but we're prepping to poke the bear. So give us a sense of what's going on there and a sense of the problem, not problem. I mean, this is a fine balance. When we go into some of these states, you look at states like Pennsylvania, New York, and California that have complicated laws on the books. I mean, there's a lot of people doing it. Sometimes you just don't want to upset the apple cart and go in and make a big splash about something. Be careful what you wish for; you might get it, right?
So far, what we have done is what we've been trying to do is the AAFP has policy on the model that says that we are not insurance, and the CAFP had policy that recognized it as a model of care, but didn't go the next step and say that we're also not an insurance platform. And so what we did this year is put forward at the all-member advocacy meeting in California a resolution basically delineating that, stating that CAFP now needs to have not only that we're a medical practice, but that we're also not insurance as a part of their policy base. So that actually has taken a long time to percolate through the CAFP. Both of us are actually now part of two key committees in the CAFP. The resolution actually got presented at the practice management committee, which is I'm a part of. I had, of course, to present it, and then I couldn't vote for it. But basically, it looks like we have pretty good acceptance amongst everyone at the CAFP. It now needs to go to the board for formal approval. And so we're just waiting for that board session to occur in November. I don't know if you want to add anything further to that.
Well, just going back to what Garrison mentioned about trust, it's very interesting. I was telling this to Phil, where I sit on one of the committees at CAFP. People are very much discussing how healthcare completely changed in the pandemic when we truly had it doesn't matter who you are, what coverage you have, you get access to COVID shots and COVID testing. And so especially in the state of California, I think that understanding of, wow, you actually had a doctor that you could trust and who was affordable, even if you had Medi-Cal, they're starting to listen differently. And I think that it was hugely impacted by the way that people needed access so desperately during the pandemic. So it's a tough journey to talk to rooms of physicians who have no understanding about what they train to do in family medicine in particular. And they see us doing what they went to medical school to do. And it's just like, what is this world that you speak of? But it's wonderful to be able to have the trust in the ideal relationship between a doctor and the patient. Just that the trust that is embodied in our practices. I mean, look, like I love that there's two DPC doctor patient, pairs in this room, but it's because of what we're doing, harkening back to, when you were a kid, that care that is really making a difference, just like it did when we shared our stories. So that's all I wanted to add to that.
And to get into the weeds a little bit more, California is complicated because there's really two parts of insurance law that need to be covered. And one of them is just the regular insurance code that regulates the business of insurance, regulates you all, regulates physicians, regulates, auto, workers' comp, whatever, insurance. Then there's the Knox-Keene Act. And Phil, do you want to talk a little bit about Knox-Keene? It's basically the statute that regulates HMOs. And it sort of looks at you all as an HMO.
Right.
By the letter of it.
It's basically a law that, was so broadly worded that it's trying to be as inclusive as possible to not allow the insurance industry to get around it. But it was written, in the 70s? Mm-hmm. So it's not, now here we're trying to apply a clinic, I'm trying not to apply a clinic law. And I think nobody wants to challenge this because, it has been challenged before. I think about 15 years ago, a group actually tried to challenge it. And there was a whole group of patient rights advocates that came out of the woodwork that actually backed that down. So it's.
It kind of reminds me of, I did a deeper dive for New York than I did California. Maybe I should look at Knox Keene in more detail as well. But in New York, their HMO laws are quite broad too. And the irony is, if you're going to do anything with DPC of any kind of size in New York, the way the law is written now, you almost want to be an HMO. Because that's the only way to legally do it, is to do what they call very limited service HMO. And Knox Keene forces people to make kind of weird decisions too, if they were trying to do anything at scale. But they would have to sort of, rather than trying to say we're outside of it, pay all these fees and try to fit in it.
And we have just a group of us in California have put together a website, calidpc.com. And we have, I believe we have a resolution verbiage, especially for those people who are interested in more. To read the verbiage, we defined it as we are not in the business of insurance, and that direct primary care is a relationship between a physician and their patient. And so this is the verbiage that, if it is accepted, clarifies on those 2 points and then is part of the CAFP policy. So calidpc.com should be there, but if it's not, we'll fix that. Yeah.
And so, I mean, I think it's safe to say, we've probably passed the DPC is not insurance legislation. In most of the states, it's going to pass it. I think in California, in New York, and other places, we might be looking towards some sort of regulatory guidance that says, hey, we understand this might look like it's a duck, but it doesn't walk like a duck, so it's a different thing. We did this in Massachusetts a few years ago. We really sort of followed the same model. There was a local direct primary care coalition established in Mass, still pretty active. Dr. Jeff Gold from Marblehead, Massachusetts, really spearheaded that, and he took the time to go ask the insurance commissioner opinion about whether or not what he did was insurance. And the insurance commissioner at the time, this was under Governor Charlie Baker, who was an insurance executive, a health plan executive before he was governor, looked at this and said, no, it's not. If you follow these rules of the road and you don't go beyond the scope of a primary care practice, we don't want to regulate you. We don't care to regulate you. We don't think that you are in the business of insurance. So that regulatory guidance has the force of law in the state of Massachusetts. And this is a model that we think might work in some of those more complicated states where you might not want to open up Knox Keene in California legislatively, because then, as you put it, everything comes out of the woodwork and we get into a large battle, and it's difficult to move forward because you're mired in conversations about things that you never intended to be involved in. So keeping it small, keeping it simple, providing some sort of a clarification might be something we do. I think it's likely something we do in Washington to clarify about this report that we've had to do every year as well. So I think we'll be less going in passing a lot of laws and more perhaps tweaking what's there and we're providing, ongoing regulatory support and guidance.
Yeah, see, I mean, as I pitch direct primary care now, I pitch it as a culture. It is a way of understanding what the incentive should be around healthcare so that they don't screw up the healthcare, so that they don't make it too expensive. They don't allow greed to get a foot in place. Where we're working to make a living, not a killing, where our only objective is to have the patients do well. And we need to protect that culture by not surrounding it with a bunch of triggers that will make it worse. And that regulation trigger is one of the potential things that will make it worse, because they they're fighting in a different world. They're fighting insurance companies. They're fighting big clinics. They're fighting medical malpractice stuff. What we're doing is trying to create an ethic for healthcare that may, I hope, catch on in the rest of healthcare as we grow. And as people see that this is something they can trust. Because when the trust happens, then everything else happens. I get to talk about this tomorrow, which will be super fun. But this is, for me, this is the proof here. Direct primary care does not tell any doctor how to practice. You don't have to be certified medically. You know, you went to medical school, you did your residency, you're still working at your sport, you're trying to be better at your science. The thing that we're doing is we're drawing them into this incredibly warm, comfortable culture that allows them to do what they had wanted to do when they went to medical school. So once you identify like that, then fighting about whether you're an HMO or not is ridiculous. All of that other stuff sort of falls away. So that's kind of the way I'm sort of looking at how this thing progresses if we're good at it. I'm just shocked we're as good at it as we are. I mean, just getting the words for this. I mean, I can tell you how hard that was at the beginning, and it continues to be because everyone else is stuck in their insurance head discussion. And we're talking about, no, well, fewer middlemen, less interference, less, how can we make this into $1 billion business? And more, how do we make patients healthier and more independent of the healthcare system? How do we reduce the craziness? Not how do we increase it?
We can get an update to the slide. So in the last few weeks, Alaska's passed the direct health agreement.
Yep.
So that was a bit of an uphill battle for a couple of years. You think Alaska being a frontier state with some of the most expensive healthcare in the country. A huge need for primary care would be really quick to the table, especially understanding all these other states have passed law, but it was a bit of a interesting battle there. But that just passed here recently, and there's already primary care clinics poised and ready to take care of employers in January.
That's good to know. I was not aware of the
They call
thing.
it the direct health agreement. Some of the say legislators trying to oppose things or trying to insert language or doing things like saying, yeah, you have to be, in order to offer direct primary care, you have to have the majority of your business owned in Alaska. So say you own a DPC business in Colorado and want to open up a DPC business in Alaska, they were
Not for
some opposed, but they tried to insert that.
They didn't convince you to move to Alaska?
We already have friends in Alaska that have been, Dr. Wade Erickson's an Alaskan, takes care of the governor, and his company's called Capstone Primary Care, and then they now have Capstone Direct Primary Care. And they've been chomping at the bit to get this passed. So fortunately, it's happened.
Cliff, perhaps you could sum up for people who are facing this in other states. What was really the power, the vested interest, the funding behind the resistance to what to everybody in this room sounds like, wow, this is a really good idea. Let's do it as quickly as we can. Who was funding the resistance and why?
I think just some broad strokes there. Having testified, myself and a number of other DPCers.
Yeah, as have I.
Yeah. There was protections for the state citizen, and there was concern on that front. There was concern that the cost would be potentially too much. But again, these were, for those of us that know, like the average per member per month for primary care is less than $100. There was concern, and again, this is a place where there's already tremendous shortage of primary care. There was concern that there would be physicians peeling off of, let's say, Medicaid and or their existing payer relationships to do direct primary care, which would make the primary care demand even higher. There was concern that it was insurance. So fortunately, in the law, it says it's called direct health agreement, and it says that this is not insurance, therefore not to be regulated by the DOI. And there was an interesting DOI battle there a little bit.
I would characterize it as well as sort of momentum. I don't think there was a lot of organized resistance to this from the insurance community. I don't think there was a lot of organized resistance to this from patients advocates or the left or the right in any way, shape, or form. I think it was a question of a legislature that wanted to make sure all of the T's were crossed and the I's were dotted appropriately, and they just took 6 years to do it. I mean, so, and as you said, I wasn't even aware this bill had passed and kind of where it stood in terms of disposition. But you know, what I found was they at one point they had invited the insurance commissioner from the state of Washington to come and testify, and a staffer from that office did come and testify and said, well, yeah, we consider this insurance. And we regulate it as such, and everybody who's in DPC has to file a report with us every year. But forgot to testify to the fact that it says in that same bill that this is not the business of insurance. The same thing that the Alaska state law has now done, and the Washington state law was the first to do as well. So I think the reality is there's a lot of fear and misunderstanding about it. I think there's some historical mistrust of allowing physicians to do their own thing without a large regulatory structure around it. We all know the reason Blue Shield is named Blue Shield. It's to protect you from your doctor. So who all in this room, who all in this room feels you need an insurance company to protect you from your doctor? The time has gone by on that rhetoric, and I think we all understand that things are different. But in Alaska, as has been the case in a lot of other states, Pennsylvania, the regulators get their back up and want it done a certain way, and it takes them a long time to come through it. And I think we've done a good job explaining what it is we're trying to accomplish to the point where it's now, okay, how do we do this? How do we structurally make it fit in the current state law, regulatory structure without, completely, throwing the baby out with the bathwater?
I think those are great comments, Jay. Part of it, like I said, compared to Nebraska, quite a conservative state where I'm from, we had a senator champion, Senator Reeby, that really did a great job, had a symposium, brought in all kinds of different players to kick off the bill. This is back in 2015 or 2016. So we had a Senate champion that was prior Children's Hospital CEO executive in his kind of swan song days of the Senate there in Nebraska, saying, hey, I get this, and I'm going to bring along a whole crew of Democrats and Republicans, and we're going to have a symposium and invite a variety of different players, both policy people as well as physicians. And he really orchestrated that well, and I would give hats off to him in that symposium, because it laid the groundwork. And then we testified, brought physicians in and testified at committee level, passed unanimously out of that, and then passed Nebraska as the unicameral. And for those that don't know, there's not a House and Senate, there's just the one, because we have to be different. And it passed unanimously out of there. Governor Ricketts, a Republican governor, signed that into law, and it was smooth sailing, right? And it said essentially DPC is not insurance in this conservative state. And I'll never forget, because we had a luncheon as part of that symposium at Blue Cross and Lincoln. This is in the early days of DPC, so they hosted the luncheon for us. I'm like, this is kind of fun. They're paying for lunch. So I give that as an example, is this is a state that really did it right. And Colorado and some other states have done that as well over the years, where you've had these champions. In Alaska, while we had some physician champions, I don't know in the legislature if there have been people like Senator Reedy that really say, hey guys, this makes sense, whether you're Democrat or Republican, and let's move this thing forward. And it passed unanimously.
Well, that's what we've experienced with almost all of these bills. I think virtually, I don't even know of a one that's passed with. I think Virginia, we had some dissent on the Democratic side at the end of the day. We passed it unanimously, I believe,
Yeah. A lot
in the
of
House of Delegates.
I just looked up the Alaska one that passed last week. It was far from unanimous, but
Okay.
most of them are.
Has it been signed by the governor yet, or is it?
Yeah, just last
great.
week.
It's great news.
Yeah.
I didn't know they were still in session.
Yeah, and it's a weird thing to me. I mean, I know they contacted you and they contacted me probably the last 2-3 years. I didn't hear peep out of them this
No.
year, so apparently I was holding things back there.
Well, that points out that what Garrison would agree that a movement grows glacially. Sometimes it feels when you're trying to make it go faster, but at the same time, a movement grows at the speed of trust.
Have the hospital systems been an issue in the last quarter?
So the last bit of the article is funny you say that, the hospital systems were neutral.
Yeah.
Thanks, hospitals.
So we usually find. And to be honest with the insurers are usually opposed until they're not. When they realize it's going to pass, they weigh in and they say, here are the things we want. In Virginia, I remember they wanted, they just simply wanted physicians to, bill in arrears. I think it was put into the law. So you had to bill in arrears instead of upfront. Maybe kind of a pain in the ass, but it was the cost of getting, the Anthem Blue Cross.
Discharge and enrollment.
And it just, we did it for 2 sessions and they asked the governor to veto the bill, Governor McAuliffe to veto the bill, and he did, against the wishes of employers, physicians, patients, unions, medical societies and everybody except, one stakeholder, which was insurers. And at the end of the day, when it came back up, it was really a pretty simple administrative ask that they had. And, it's in the law. So each one of these laws does differ a little bit, but essentially all they say is that, hey, this is primary care. It's not insurance. It's regulated by the state medical board, just like any other primary care practice would be, regardless of what their payment model is. And it's pretty tight. We have model legislation. It's actually up on the website. Phil drafted it. And it's the basis for these now 34 different bipartisan state laws. But most of them have passed overwhelmingly, either unanimously or with almost all support, Democrats and Republicans. It's been great. And in fact, in a very real way, we're gonna shift on to the federal conversation. I think Margaret's trying to find Representative Blumenauer. But in a very real way, it's really what we're trying to accomplish with the Primary Care Enhancement Act is to make the last place on earth where there's a regulator that still thinks that this is some sort of a health plan or insurance, which we'll get into in a minute, is really the reason why we have the problem with the HSA and the high deductible health plan that exists. And I'm gonna flip the slide over here so we go to the next one. Margaret's down.
Quick question for the group. Especially in more populous states that have large integrated health systems, do you find that those integrated health systems are on the other side of this issue because they see you as competitors? Have you run into that at all?
Not yet.
Not at the state level.
That's good.
It's usually the insurance companies.
Okay.
Yeah, that's the next
Good to
one.
know.
That's gonna happen.
That's what the special.
Yes, because they've got to see you with an Amazon or a Boeing. They've got to see you.
Well, I will tell you though, they're on you. Let me tell you a story as a patient. Okay, I was skiing with Clint a couple of years ago in Utah, and my Apple Watch went off, and it said, "Hey, you might have AFib. You should talk to your doctor." And I said, "Hey, Clint." Now, we might have had a pint or two the night before, and Clint said, "Well, I'm not really too worried about this. You helped me download the EKG. Remember, and we took a little EKG and we found, it might be a little weird. You should go talk to a cardiologist." So Clint told me, "Yeah, just like the Apple Watch told me, you should go talk to your doctor." So I did, and Dr. Hayden referred me to a cardiologist that was in my network. And I went to see the cardiologist and said, "Yeah, you need to get an ablation. You should go do this as soon as you can. And we did that. As I'm getting ready to go to get the ablation procedure, I got a memo from my insurer that, hey, you didn't get a referral from your primary care doctor to go to the original cardiology appointment. I said, yes, I did. Dr. Hayden referred to me. I said, oh, well, that doesn't matter. He's not in network. So, they made me go to a Soviet bloc primary care office. It looked like it was something out of Warsaw in 1959, which I'm sure was very good care, but not the care from the doctor who knows me and knows my story. And so, I think what we're going to be facing now is a challenge from this community to make sure that we can work on legislation or regulations that would say any primary care doctor who makes a referral into specialty care from primary care, you need to take their referral. Now, the insurers will say, the health systems will say, well, that messes up our integrated networks. But I don't think people really care about that. And I think you're going to find very good bedfellows on this from the right and the left, people that want to protect consumers in this day and age that are going to be on our side.
Yeah, it's the payment models that are going to create the challenge, right? Because you now have people not part of these global payment models that are going to be able to do this. That's going to be the challenge for sure.
And we're going to pause. We just changed the slide for you, Representative Blumenauer.
Wow.
On your bill.
Look at that.
Amazing how that happens. Ladies and gentlemen, please welcome Representative Earl Blumenauer.
Thank you. That sort of tell the story.
Do you want to sit here and wear the light not in your eyes?
Well, I will move so the light is not in my eye. This way I can sort of have eye contact with real people rather than going back and forth. So I'll weather the light issue.
Do you want me to stop the slide?
That was cool. I don't need that.
He doesn't need the documents. He wrote the documents.
Simple bill, bipartisan, time to pass it.
Next slide, pass the bill.
I made a decision to wear this tie today about going for the gold. You may have noticed that this is polite. This is not the most functional Congress. Really scary. Everything I've done in 28 years in Congress, we work for bipartisan legislation. And most of them are things that actually bring people together rather than divide. This bill actually brings people together. Can you think of another adjustment that will improve primary care and not cost anything? To give people agency over their care and to provide higher quality for the people who provide care. I've been spending a lot of time working in the healthcare space. I've never met a doctor who wants to spend 6.5 minutes with a patient and starting behind schedule before they finish that conversation. It's insidious. It doesn't promote care. It leads to provider burnout and unnecessary expense and paperwork. I mean, just being able to manage the system is an additional burden and takes away from the opportunity to provide care for patients. You're on the side of the angels. We just need to make sure that people understand. We have an amazing amount of support broadly, but it hasn't translated in, frankly, getting some of my Republican colleagues having a higher priority established to this. We have a modest issue with the Senate Finance Committee. So I think there's a misconception, but it narrows down our targets, i.e. everybody you have contact with. You have to give them a nudge.
This is a no-brainer. This is not picking fruit off the ground. It's picking fruit off the ground. Bipartisan, efficiency, providing higher quality of service and satisfaction. And I think you ought not to be bashful about making sure everybody understands this. These people have almost nothing to show for what they've done this Congress. I mean, it's true. I had my last conversation in the gym this morning with a senior Republican who was shaking his head. They don't like this. And people want to have something to show for their service that they can provide for folks back home that doesn't cost anything. It saves money, brings people together. I mean, this presentation writes it stuff. I'm going to be in Congress for only 114 days. I'd like to get this across the finish line in the chaos that's going to be in the lame duck. Nobody knows what's going to happen. If the election turns out right, gives us a little momentum. But regardless, there's going to be so much flying around, so many people who are agitated about things that don't matter, that you have a chance to give them a path forward that they could feel good about. I truly think that we have an opportunity to get this across the finish line this Congress. And there are multiple paths. We don't actually have to go through the Senate Finance Committee. It would be helpful. We should do it. It would be something they could take credit for. But when we're talking about a lame duck session, there are multiple paths going forward. And we're looking for people to attach this car on any train that leaves the station. You don't need, because there aren't budget implications, because it's bipartisan, because it is a simple thing that people can take credit for. I think we ought to concentrate our firepower with everybody you know to have them help you out a little bit between now and the election. It's not a heavy lift. It's something they'll feel good about. And mobilize people back home to be heard. One thing I've learned in 28 years of Congress, and this is my 54th year of full-time political activity. But here in Washington, D.C., you make your own reality. You have that capacity, bringing people together on things that aren't controversial, that don't cost anything, and are good policy. When all else fails, some people will like to do that. And I think you need to be bold. This may not be the only priority you have. Mercifully, you care about other things. But it's something that you're not losing any political capital. And it might give you some credibility in some other places. We are in a perilous time. I have spent my entire adult life working in the political. I have prided myself on legislation and initiatives that do bring people together. All bipartisan. We've had remarkable success on everything from bicycles to marijuana policy. You didn't see my marijuana socks. People, what we've done and how we've done. This is an opportunity that is important. It's not the end of the world. It's not going to solve all our challenges in delivering quality health care, more choices for people, informing consumers about what their choices. I mean, some of you know I spent a decade being the death penalty, providing the federal government put value on the conversation of end of life. Drove me crazy that the federal government would pay tens of thousands of dollars for operations on a 90-year-old woman with terminal cancer and wouldn't shell out $125 so that she and her family knew her choices and the best path forward. It took us 10 years. So we've got to be patient. We've got to be focused. I'm just saying this can be done. I wanted to stop by and thank you for your partnership. This is one of the things I feel good about. I think we can do this in the next 114 days. I don't know, but we'll be dodging and weaving and trying to connect with people and move that forward. But this is an opportunity in a Congress that's ending in a train wreck. I mean, the far right can't agree with the extreme right about what they're going to do on the budget issues that we agreed upon a year and a half ago. And ultimately, the agreement that we made back with Kevin McCarthy is what is going to be the final numbers. But people are going to have a lot of bloodshed, anguish, tears, and embarrassment to get there. The American public deserves better. You are part of the solution that people need to embrace. I wanted to thank you for the partnership. This is something I feel good about. I don't just feel strongly about it. I feel good about it. This is one of the cornerstones of how we add more value to the American healthcare system. We can no longer afford to pay more than any other developed country by far for healthcare, which for some Americans, I mean, many of us have access to the best healthcare in the world. But that's not the case for most Americans. They pay too much for mediocre healthcare. And we need to change that. So I appreciate the partnership. I appreciate working with you right till the end of the next 114 days. If we're not there at the end, I'll be happy as a civilian to continue to be your partner. But I really appreciate it. And thanks for the opportunity for me to share some of my biases.
Thank you.
First of all, thank you. You have been a rock for us, and we appreciate that. You recognized what we were up to, and you backed it, and you helped us, and you fought a battle that shouldn't have been this hard to fight. The thing I wanted to ask you was that little problem in the finance committee. Do you have any recommendations about how we might approach that, or have you already made best efforts that can be made?
Well, I, as a member of the House Ways and Means Committee, which we think is the best committee in Congress, I'm very solicitous of people in the other body who have leadership positions on the committee they think is the most important. And I seek to be respectful. What I have done when I've been involved at home with fora that speak with healthcare, I keep this on the agenda. I work with businesses there who want this and have urged them to don't be so quiet. Deal with the companies, deal with the employees, deal with the public, deal with the media. Make a little guts.
The chairman of that committee recently proffered a white paper about how to transform Medicare payment policy for doctors. You may have seen it. In it, it says, wouldn't it be a good idea if we move to a simple, flat primary care monthly fee for Medicare? So I think there's been some changes in certainly some recognition that the model is working and it ought to be adopted for Medicare, which the Finance Committee and the Ways and Means Committee both care about greatly. Now, this white paper obviously isn't a bill yet, but I mean, they're thinking about this in a new way, Representative Blumenauer, than they've had in the last couple of years. So I think it's a pretty easy juxtaposition to say, yes, we think that's a good idea, but we also think it's a good idea with high deductible health plan, HSA plans, people have access to the same kind of care too.
relatively short step. And we always need to help people connect our dots. And I agree with you. Part of it is getting all caught up on HSA. You know, it's not my preferred model for American healthcare. It's expensive and it's not necessarily equitable, but it's here. And millions of people participate in that. So what I've attempted to do with my Democratic colleagues who are reflexively against it is to let's deal with reality. We're not going to repeal that. Too many people are invested and there are benefits to it. It's not an unvarnished negative. It's not a substitute for what we need to do, but being clear with people about that. But your point is right. Take elements where there are agreement and help people understand how to expand that agreement and get more benefit for the American public and credit for you.
Any thoughts about what's going to happen here in the next couple of weeks? Are we going to have? It sounds like you're a believer that there's going to be a lame duck package, that we're not going to fix the world between now and September 30th.
That's correct. Going out on a limb there, we're not going to fix the world in the next 3 weeks.
That's still the message. Let it make it be part of the package. Anything that's right.
You need to be available at any step along the way. We're going to be around in November and December, taking advantage of that to have people understand reality, to not let up. I mean, many major groups and organizations, this is when they kick it into high gear. And there will be trains leaving the station and garbage trucks moving and any moving vehicle, they want to be a part of it. And strange things happen here. Those of you who've watched, you don't even have to watch very carefully very long. Strange things happen. And there is serendipity where all of a sudden there's an opportunity. All of a sudden people need an item to save a little money for a project they're working or trying to help somebody else move forward. Anyway, yes, I anticipate my last 114 days are going to end back here in your nation's capital with a lot of people wandering around being frustrated. But you can be focused on what you care about. You know, there's a finite number of targets. You've got a very strong message, and I take advantage of it.
I heard you say that this doesn't cost anything, and I agree with you. Not everybody has agreed with us on that. We've had some scores that were a problem. Have you encountered, is there anything new we can say on that front to sort of overcome those inaccurate estimations?
Well, being able to reconstruct your case for why it is not expensive, it doesn't have a cost, and it actually provides better care for less money. I mean, I think you continue to promote your model, give your experience. Why do businesses want to take advantage of this? I mean, it's pretty compelling. And I've spent a lifetime arguing with CBO. They have a problem dealing with present value accounting and life cycle costs. And many of my Republican colleagues at CORE understand this. So we push back on CBO. I periodically have pleasant meetings with the director thereof, and try and be clear how Because ultimately, it's not going to be a CBO score that's going to settle it. Ultimately, what's going to put us where we need to be is public support for a strong, effective model that improves the quality of care and choices for people with less administrative burden. I mean, that's your mantra. Keep pounding away on it.
Well, I'll remind you, as you know, there's a Milliman study. Don't believe us, believe the actuaries. The Society of Actuaries says that a company that provides this direct primary care benefit, in addition to their PPO, will save, roughly 20% of the claims cost for that company by providing more care in primary care. Unfortunately, what Congressman Blumenauer was talking about is that CBO doesn't look at that as an offset because this is tax revenue. They're apples and pomegranates. So I think you do have a story to tell about savings, even though you have a story that you need to get around about what the score of the bill is.
Yeah. And Jay, I think that there's also a role to play with local media. People care about healthcare. This is kind of an interesting story. It's a way you can draw the curtain back from the legislative process and sort of the, why can't we do this sort of thing? I would just be relentless in carrying the message. The media, along with people at home, folks who have town meetings, being able to plant this. You should have your people stalking folks in the political process about what you're doing and why you're doing it. And again, you have a life. This isn't the one thing that you are focusing on, but it should be one of the things you focus on. Having invested so much and being right. And frankly, I will just conclude by saying, I think the political process needs you. I think my Republican colleagues are not all intent on bringing things to a halt and being all Trump. Many of them are here who want to do their job and make things better. So this empowers them. So anyway, I appreciate the partnership. I appreciate what you're doing. I hope that you will take it as seriously as I have, because I spend a lot of time and energy supporting you in when the opportunities arise. And we need you to do your part. Thank you very much.
Thank you.
Thank you. I want to recognize Dr. Samuel, Representative Blumenauer's legislative assistant on health, and she's done an amazing job putting a lot of action behind what the congressman.
Yeah, Ashu's got her foot on the accelerator for all of those 114 days.
Thank you so much. All right, Jay, have a good time. Appreciate it. Thank you, sir. Happy to do it. Thanks for coming by and keeping the gas. That's okay. Oh.
Come to understand. That was Jay, who had a relationship with him.
Talking to me and Jay about seeing my to-do list. I'll see if I can.
Outside the gym.
Assurance. I'm going to ask Ben Wise to sort of kick off. And Garrison, do you want to talk a little bit first before we get started about how this conversation really started with you and Ben, and what and from your perspective, why we're having it?
Well, actually, Ben's probably the right person to talk about.
All right.
Yeah.
I didn't bring a lot of flyers, so I'm just gonna put a few around the table. This is just some information about our agency. And Dr. Bushman is actually a client, Richie Partnell, and my colleague Scott Selman.
All right.
Yeah, so most of these inquiries come from outside to us. People who have heard about this, and it's what they, and it sounds like a way they can apply themselves and what they know is something that sounds like it's actually going to do a lot of good. Because in business in general, there's a lot of, some people benefit and some people don't from it. And it's nice to be able to look at something and say, nothing but good will come of what we do here. And we really want to support that, which is the way DPC wants to relate to the rest of the universe. We don't need people who necessarily tell us how to do what we do, but we do want people who believe in what we want and in the culture that we've created. And there are lots of people, there is a huge ecosystem beginning to form up. And insurance intrinsically has issues that in terms of the history of health insurance itself, and what that has done to the healthcare system, and fixing that problem is just as big. It is going to be just as big a project as fixing primary care was, and these are people who are pioneers on that level who really want to come and figure out what it is we're doing and how they can do something that runs parallel to that we who are most afraid of these big organizations can get comfortable with and can benefit from, and have some peace. Let them do the stuff that they do so we can do the stuff that we do. Anyway, that's my background. So go ahead.
Thank you, Garrison, and thank you all for your time today. I'm really happy and excited to be here and meet with you guys. I've spent about 20 years in medical professional liability, and in our sector, we very closely align with the mission of DPCC. We're all about supporting independent physicians. For med mal insurers, the pool of available insurance is ever shrinking with the consolidation under health systems and physicians becoming hospital employed. So it's part of our charge and mission to support independent practices, to help them thrive. And, when I started researching DPCC, I was just really thrilled to see that, because, you hear all the doom and gloom at all these med conferences about, the employment trend. And now to start to see the tide go the other way is really exciting. So I love what you guys are doing. I've spent my career doing that, advocating for independent practices. And the reason I'm here today is to deliver some good news, is that this organization, as far as med mal insurance goes, has more power and leverage than you may have realized before. So I started out visiting with Garrison. I was like, you guys have a med mal program in place, and it looks like it's, everybody kind of makes their own path on that, and there's so many carriers out there, so many choices. It's very scattershot right now. But so after talking with Garrison and Jay, they were like, we would be interested in seeing what some med mal carriers could do to put together some coverage programs for our membership. And so over the last few months, I've been having conversations with some of our carrier partners. We have two of them here today, ProAssurance and Indigo. And I'm happy to report that, we've looked at some data, some analytics for a sample set of DPCC members. And the results have been consistent that you guys are a really preferred class of business. Feel that the risk is low and especially lowered by the model of DPC, having smaller patient panels and, being able to spend more face-to-face time with your patients. Excuse me. Anyhow, so as you guys know, insurance is a game of numbers, and you guys have large numbers that you can put together, and the end result will be is everybody in DPCC would get a better deal on their med mal. So that's the news I'm here today to share. Is that we have a couple of carrier partners that are really interested in talking about capabilities of what they could do in a coverage program for DPCC members, not only to eventually deliver a lower premium to members, but to help you guys reduce your risks in practice, as small as that may be. It's really important to be on the front end, implementing risk management tools and analytics, and ultimately being able to deliver even better care. So with all that said, I'll be around after this for anybody that wants to visit, and I'll hand out cards to anyone. But I'm going to go ahead and turn it over to ProAssurance, and they'd like to talk with you all about what they see in DPCC and what they might be able to do for DPCC. So thank you.
Before we start talking about ProAssurance, I said earlier I wouldn't bring the room down by talking about what's going on, so I'll do it now. I thought it would be a good, just as briefly as I possibly can, to kind of set the stage for the world that we are all living in right now. It is a different world. It is a world that has come about, I say, in the last 6-7 years and continues to trend in a direction that is not particularly positive. While the frequency of malpractice claims over the last 20 years has gotten to the lowest point that it's been in the almost 40 years that I've been doing this, the severity of claims is at an entirely unprecedented level. And unfortunately, what we're seeing in addition to that is that causation is no longer necessarily linked to the outcomes of these cases. For the first time in the history of the malpractice industry, over 52%, over 50% of courtroom verdicts are now over 8 figures. That has never been any, just 4 years ago, that was under 20%. There was recently a case in Indiana where causation really was infinitely defensible. There was really no cause and effect with what happened and the medical care provided. The plaintiffs in that case, I think, were asking for something like $10 or $11 million, and the jury awarded $25 million. There is a combination of circumstances that are leading to this. I think DPCC is one of the answers, because one of the things we do know is one of the reasons this is happening is because of a very significant frustration in healthcare, in the provision of healthcare. That 6.5 minutes that we were just talking about, that's problematic. The nameless, faceless organizations that are providing care, that's problematic. And organizations like this and solutions like this help bring us back to a type of medicine that was significantly different. And that type of medicine did have an effect on malpractice claims. Whether it was the late 70s or early 80s, there were studies done out of the University of Toronto and Harvard that talked about the importance of the physician-patient relationship and how that relationship affected willingness to go after somebody for malpractice. So, what you all are doing, I think, can have a huge impact on what we do every day. But I think it's also important, as you are looking at malpractice options, that you understand that, unfortunately, that's what we're all dealing with right now. And the severity of claims is not going to change direction anytime soon, because it is likely to take legislation of some type to get this pendulum swinging back the other way. So I think we're going to continue to see it get worse. I think it's something we have to make sure we're aware of. This isn't a question of how often we get sued. It's a question of what happens when we get sued. So I thought I'd just set the stage for everybody, and then we can talk about what we need to talk about, which apparently is pickleball.
Pickleball, yeah. So, first of all, thanks everyone for letting us come here and speak. I'm going to stand up. One of my many talents is standing and speaking. One of my many weaknesses is sitting down and speaking. So I'm going to stand up and walk around. I talked to a good friend of mine who's a lobbyist in Tallahassee. I asked him, I said, I'm going to Washington, D.C. I'm speaking in front of a group. I said, as a lobbyist, how do you get their attention? And he said, I bribe them. So I decided to get a pickleball paddle. This is Pro Assurance, because I know we've talked to Dr. Bliss about his bubble pickleball and where it was invented. I presented with this to get it started. I said a good bribe right from the jump never hurts anybody. As long as no one's paying attention.
Thank you.
So thank you very
I
much.
should warn you that I have a Kevlar.
When I saw that, we were told, we were like, no, this is not a good pickleball paddle. It's the thought that counts.
It's a theoretical. I will accept. Thank you very much. I can be bought.
I do like that cover though. That's pretty nice.
Well, they pulled it out at TSA and they spent a little bit more time looking at it than I was comfortable with. In fact, I was like, can you please take it out so people don't think I have a weird paddle? I show people a pickleball paddle. Because I travel through the Baton Rouge airport quite a bit. They all know me. I want them to know that it's pickleball, not for anything else. But that's beside the point. Do you mind going to the next slide? I've got the real honor of talking about the dessert first, and then we're going to leave it over to the state. What Pro Assurance does best, in my opinion, is everything that you don't think about when you think about medical malpractice insurance. When I talk to a doctor about malpractice insurance, what's my premium? And that's very, very important. But there is so much more that goes into it from a malpractice company. What Mike touched on a little bit earlier, the environment that we're in. And one of the things that I always talk about, and I never hesitate to mention this, anytime I talk to a group of doctors, if you are concerned with anything within the medical community, you cannot leave it up to the insurance companies to advocate for you. You cannot leave it up to lawyers to advocate for you. If doctors want to make a change, doctors have to go directly to their congressman, the local congressman, at the state level, at the city level, at the state level, at the national level. If you want to make a change, specifically in malpractice, you have got to advocate on your behalf. Congressmen, they don't so much enjoy listening to insurance companies. They don't so much enjoy listening to attorneys. So it's really on you. So unfortunately, in addition to being doctors and practicing medicine and being married and raising a family, I've given you another job. If you care about this industry as a whole, you've got to advocate on its behalf. And the strongest, a lot of the folks in this group have to pull up the weakest. Because again, insurance is a numbers game. And there are radiologists who practice spinal surgery and do telemedicine do Botox via telemedicine. I'm not making the combination up. As an actual submission that we saw, all of those three things in one. So you've got to advocate for everything. So that being said, Pro Assurance put together a really aggressive package.
We didn't insure that, by the way.
No, we didn't. And I call it our 5510 program. It can go as far as 5520, but I had to put 5510 because underwriters saw this PowerPoint before I actually put it out there. So the 5510 program is really unique. So anybody within the DPCC program is going to get 5% right off the bat for continuing with our risk management program. They're going to get 5% off their premiums for being claims free, and they're going to get 10% up to 20% depending on the venue that they're in. And I have a slide that's coming up later that's going to show you the value of being in a state that is a little less litigious. For example, so New Mexico, for anybody who's in New Mexico, it's a difficult state to practice medicine. My state, Louisiana, is an outstanding state to practice medicine in. We're going to show you kind of the different variations for that before I turn it over to Mallory, who is the stake for this presentation, all of the important, the good stuff we talked about. The second thing, the underwriting, we're going to be individually underwriting every single risk that comes through. We hope to eventually put together a group policy for you, but we're going to take the time to individually underwrite every single risk that comes through. We want to understand what each and every doctor in this room, on this panel, in your coalition does. We want to understand what they do well, what they struggle with, where they want to grow their practice, what states they're practicing in. So we're going to take the time, we already put the mechanisms in place with BID to do this effectively. The second thing is our marketing. This right here is our provisions manual. I put a copy. You should have one in front of everyone. If you don't, let me know. This comes out hard copy and electric or digital. This is our best marketing tool. We can partner with the DPCC. We can help advertise for you. If you've got events coming up, we can put it in here. This is a great way to find out what's going on within your state, within your specialty. Anytime you have an article that you think would be interesting to us, we run it through our compliance and our marketing team. We can help add it in for you. We've got an entire marketing wing that's willing to take on a lot of the burden that is very cost expensive for a group like this and help you advertise. Help you advertise to grow membership, help you advertise for events. If you've got an important article, if you've got legislation in, we can send this to all of our doctors, all of our brokers throughout our platform and help get that information out. And that leads to the last part before I turn it over to Mallory is growth. We want to grow with you. We want to help this group grow. So anything we can do to partner with you, I mentioned our Prohibitions magazine, whether it's speaking, whether it's getting our really outstanding risk team to come and talk to individual doctors, to talk to groups, to really help grow this product. That's what we want to do. We see this as the future of healthcare, which a lot of people in this room are excited to see it as well. So we want to help you grow. So if you have ideas, things that come up, things that you'd like some help with, that's when you reach out directly to myself, reach out directly to Ben. We'll be more than happy to help you grow. We really appreciate this opportunity. We're really excited about it. I've got one last slide. I apologize before I turn it over to marketing or turn it over to Mallory. This is what it looks like on a state-by-state basis. You can see this is the incurred loss in our DCC ratio. The DCC ratio is basically a combination of what it costs to pay the claim and what it costs to fight the claim. And ProAssurance is going to bat for our doctors. I think in the Southwest and the Southeast, we have it combined. It's over 89, it's not quite 91% wins when we go to bat for our doctors. So we're not just going to leave you hanging out to dry in the event that you do have a claim issue. But you can see in some states, Georgia, for example, over 90%. Florida, right in that mid-range, 76 to 90. And you can see other states that are below that 76% overall loss ratio. Those are the states where it's advantageous right now to practice medicine, which is a doctor's job. But it's not trending that way. If I see this snapshot a year from now, 2 years from now, this was a completely different slide 3 years ago, excuse me. Every year it's changing. Severity is clicking up. Frequency, even though it's not on the rise, we're starting to see it move up to post-COVID levels, which is a really difficult position for doctors to be in. If we see any increase in frequency, along with a continued increase in severity, it's going to make it difficult to practice medicine. And we all bear the responsibility of that, whether you have never had a claim in your 30 years of practice or whether you've had multiple claims, again, over a long practice history, we all bear the responsibility of making sure we're moving in the right direction. So now that all of that is out of the way, I'm going to turn it over to Mallory and her team, and or Mike, if you have something.
Yeah, I want to make sure everybody in the room understands what this map represents. What the ratio is this is how many dollars are being spent for every dollar in premium being paid. This is an industry-wide. So if it's over 90%, that means over 90 cents of every premium dollar being paid in that state is being paid back out in terms of either defense or indemnification of claims. Anything in yellow and red is not sustainable over the long term. So rates have to increase to be able to match what's happening. And that's about half the states in the country. And we expect, unfortunately, like I said earlier, this trend to continue. And it is driven in large part because of the severity problem that I was talking about. Because when you have severity, not only do the indemnification payments go up dramatically, but plaintiffs' lawyers get emboldened. So defense becomes far more expensive as well. As a matter of fact, in the last 3 years, the indication it is increased by about 75%, just defense costs alone to defend claims. Because plaintiffs, if I'm a plaintiff's lawyer working on contingency, and it's going to take me 3 to 5 years to litigate something, and my pie in the sky dream was $5 million, I was much more willing to come to the table and be reasonable. If now I think I can go for 25, 30, or $40 million, now I'm not so eager to come to the table. So the defense becomes a whole different beast for those firms that are defending our physicians. But I just thought I'd clarify that. So for those, any questions on this or any of the? All right, great, thank you.
I also fall into the camp of stuff where I can't talk. I'm a lawyer. I gotta move around. So first, thank you. think that's really where I would start, because I don't think I had appreciation of your organization just from research and looking at it until I started hearing the stories that you guys all told, the way that you're run. And honestly, I wrote down envious. I think other primary care physicians would be envious of you guys and the opportunities you have and what your day-to-day looks like, because it is not what most providers are dealing with. I also wrote down burnout, and I would be so interested to see how it looks in your practices compared to everyone else, because you're not dealing with bureaucratic tasks. You're not having to worry about reimbursement. You're able to really provide care, which is why each and every one of you that's a physician went to medical school, wanted to do better, wanted to do good. So first, just want to say thank you. And I think our goals are very much in line. I'm risk management. So lawyer by trade, risk manager. I've been about 10 years with ProAssurance doing risk management. Prior to that, I litigated malpractice cases, other civil litigation cases as well. And really just wanted to basically see that we are on the same team. We very much value the same principles. Communication, that physician-patient relationship is at the heart of all medical care. So it's just very interesting, and I appreciate you sharing your stories with us. Okay, get to the first slide. This is what everyone else in the industry is dealing with. I want to try to give some level of comparison, because the medical malpractice industry and the MPL Association have not really caught up to you guys. They don't have a specialty breakout for concierge, for direct primary care, for something unique as you guys. And this is as close as we can get to what other primary care, family medicine, internal medicine, pediatricians, some urgent care. You can see all the different variations, what they're dealing with and what types of allegations. So hypothetically, in my mind, at worst, you may be looking at something in a diagnostic error range for a potential allegation by a patient. Hopefully in your situations, your patient communication is to the level that this never reaches that you're able to have those open communications, that you can get in with your physician who may be on a ski trip with you in Utah or wherever it may be when you see that there's a hiccup or something that needs to be evaluated at a greater level. But this is what your other folks in the industry are looking at. My hope is that you become such a distinction that we're able to take you out of this. You are no longer family medicine or internal medicine. You're almost your same separate breakout. You are a separate entity within medicine. And that's what you guys are doing. You're on the cusp of it, obviously, from a legislative standpoint, to be as far along as you are in these 10 years since really beginning it. And it's just unique to see that and how we hope to be able to partner more so with your individual locations. You'll take it to the next slide. This is just generally what we do. Pretty standard risk management program. However, many carriers are reducing those opportunities, reducing the level of offerings that you have when you pay that premium. Obviously, we hope you never have to cash in from the standpoint of having a claim, but at the end of the day, you want some value-added services, whether it's CME, programs, seminars, whether it's publications, as Steph mentioned, partnering with you guys to have that niche market where we can also be a leader with you in this industry. Could be assessments. That's something that I think I would be most excited to get with you guys and be able to promote this risk management service. You'll kick it to the next one. We have what's called an annual baseline self-assessment. It goes to every practice that wants to be a part of it. For some, it could be that premium credit option, as Steph mentioned. It is a 15-minute basically survey, all virtual, done by every person in the practice. So obviously you have a lower head count sometimes, but it could be your medical assistants, could be you as a physician, you've got a practice manager, or someone who's helping assist from a nursing standpoint. Everyone fills out this survey, and it gives you 10 different audit categories. Everything from patient communication, emergency preparedness, various ways for your individual practices to address what's going on in real time with staffing changes, with maybe a new opening of a DPC clinic. Give them a good idea as to, are there some areas for improvement? They may come back and say, hey, everything's good. We'll see you in a year, kind of like your yearly checkup that you do with a lot of patients. Other times there may be more feedback needed. So it could be additional resources, really just giving folks an idea of what does it look like at this moment in time within their practice and how best can we address those minor issues. Could be something from a diagnostic standpoint, communications, could be referrals. Obviously, that's going to be a hiccup for almost any primary care physician if you've got to refer out to a specialist. So just being sure that your unique model, this would allow for that to be evaluated each and every practice, but then also rolled up to see, hey, is DPC doing better than everybody else? I have a feeling you likely are, but it'd be nice to have that data set to show as a publication piece and really to promote you guys and what you're doing. Next up. This is the one I wanted to spend just a little bit of time on. It's kind of our fourth bucket, which is a helpline. It's a consultation line that's available 8 to 5 local time, all across our country. So it could be on obviously East Coast time, 8 a.m. Eastern time till 8 p.m. actually Pacific time, 5 p.m. for you guys, but could be something that your providers may need to call in and ask a question. Within 24 hours, we respond to 98% of folks calling in or emailing same day. So if they have a question, a quick follow-up. Hey, I think I might have had a flight data breach on accident. I gave the wrong patient the wrong labs. What do I need to do? Could be, a situation where they need to possibly look at the contract with a non-compliant patient. Maybe somebody that's paying their fees bi-monthly, but really not an ideal candidate for the DPC model. They'd be able to reach out and have us as a resource. We are nationally routed across the entire country. We have 5 regions with 20 individuals who report up to me. They are all either lawyers, physician assistants, nurses, previous practice managers, or risk managers from a hospital. So it's all very experienced clinicians and other kind of just professionals who are able to answer their questions, as you can see, sometimes immediately, 2/3 of the time. Pick up the phone, answer the question. So that would be something that would be available to your DPC clinics that decide to come over to ProAssurance. One other thing I wanted to mention, you're good. You can go ahead and switch it. Obviously what makes this different, but more recently, as you mentioned, serendipitous a few times, I think today, actually had a call last week into our hotline. They got routed to one of our consultants, the DPC clinic. They're not open yet. They're in the early stages, and he had a lot of questions. He had a number of your valuable resources. He had the policies and procedures. He had sample forms, but he just wanted somebody to talk to. He was actually an individual, a physician who'd left a large healthcare system, very much like the stories I heard today, to go out on his own with DPC. And he was already a ProAssurance insured with the large health system, decided to keep his policy with us individually for his DPC clinic. And he reached out just wanting to know, hey, I'm a doctor. At the end of the day, I've never run a business before. Never had to really employ anyone. Got some questions. How do I make sure I'm compliant with OSHA requirements? How do I help make sure my lab is certified appropriately? Some of the things that he just could have probably found through documents or an email chain, but was able to reach out to us directly. He's in a location that's very easily accessible to us, being in national territory. And one of our clinicians is actually going to go down and just help him out. Go spend the day with him. Go spend the day with his wife, who is helping from a practice management standpoint. So just a quick example of how we may not be needed from the standpoint of some of your traditional risk management services, but we can add value to your clinics and be a resource to anyone who's a part of your coalition. So why are we different? We've got that national scope. We're can write in all 50 states and District of Columbia. We have tailored resources that we definitely want to partner with you guys on. I think that's something that I see as a huge opportunity with your group and the number of clinics you guys have. We have that smaller town feel. We have that regional approach where if you have a clinic who's just opening up and really just wants a partner to go along with you guys, we're happy to provide that to them. Staff and expertise, like I mentioned, from all different disciplines that truly, if I don't know the answer as a lawyer, a lot of times I'm calling one of my nurses, one of my physician assistants to ask them kind of those more clinical based questions. As shown by the call log, exceptional customer service. I challenge almost anyone to find a customer service centric industry that has a 98% within 24-hour turnaround time. Pretty good. And also we're using our own data to drive our offerings to make sure that we're staying current and are able to move their positions and be in the best position that they can. With that, I think Mike got a few other points, maybe. If not, I'm happy to take questions as well.
I would say the other thing, this is a competitive situation, and I will say that there's a couple of key differentiators that ProAssurance brings to the table as a carrier. Number one, we are in a deteriorating claims environment, and as one of the 3 biggest malpractice carriers in the country with multiple billions of dollars sitting in the bank, that's an important aspect to consider, because, insurance is a really kind of unique beast because we are one of the few industries that has to sell a product where we don't know the ultimate cost of goods sold, so to speak, for 5 to 7 years. And making sure that the financial resources are there when that check comes due is a critical component to what you're purchasing. The other thing that I will bring up in that regard is we have a third party that surveys our brokers from across the country every couple of years. And ProAssurance is the top performing carrier. As you can imagine, it's a relatively small niche in the insurance industry. So the brokers know who the players are, the brokers know who the carriers are. ProAssurance regularly scores in the highest satisfaction range when it comes to claims promptness and claims fairness of all the malpractice carriers across the country. So that's ultimately what you are purchasing when you purchase malpractice. So there are two components that I think are critical and sometimes lost in the moment of purchase because people aren't really thinking about what's going to happen if I need this product. In an environment with 8-figure claims as a regular occurrence, that's a critical component of the product you're buying. That's all I've got. Do we have any questions? Mallory?
One thing, Mallory, I think when we were getting together, one of the things that was candidly appealing to me, one of the reasons, Garrison and I wanted to sort of bring this idea before you as we seek to perhaps add additional services that would be helpful for our members because they're members of the Direct Primary Care Coalition. Is you mentioned that we would likely have a claims analyst that was really focusing on DPC.
Right, absolutely.
So that was intriguing to me because I think the thing that we've understood about DPC is maybe even it's not as much of what you're doing day to day in your practices as it is the culture, the way you treat your patients, the way you set up your office. And so explain a little bit more about how that would work. And obviously it's going to be based on numbers and that sort of thing. But
right. And I think that would be the biggest piece of it would be some level of that, but you would be able to have your kind of almost tagged, differentiated from our other insurers. We'd be able to track you guys individually that were a part of us on that policy to see, are there claims? Are there situations happening? Are there occurrences in one state that could easily be mirrored in another, or is it unique to just that one venue? We have our own, within risk management, our own claims analytics department. So we were able to take some of the day-to-day information, whether it's claims data, like I showed from MPL Association, and try to really drill down into it to see the differences that you guys make versus what we would typically put you in the same comparison category from a data standpoint. So I think it's definitely something that, and then that would translate obviously into our underwriters and things of that nature. It's something you kind of have to have a mass quantity to be able to really show that differentiation is there. And then once they recognize it.
Yeah, so one of the things but the presentation that you did for me, one of the things that impressed me was that family medicine actually is a significant portion of your malpractice risk pool, primarily because they are affiliated with clinics and hospitals that are getting sued, and they sue everybody.
Right.
And we are primarily independent at this point, or we are an organization of just primary care, isolated together to give us our independence. And my question is, I really want somebody collecting this data because I think we're going to come out at 1%, not at 15% or 17% or whatever it is nationally.
Right.
And I think that's because we've done that. And so that part of it, I think, is going to. I want to make sure of is that whoever is writing for us is collecting that data.
Absolutely.
And making it available to us.
Right.
Not only collecting that data, but with the size of a company like ProAssurance, you have much better comparative data too, because of the depth and breadth of the data that we have from across the country, across segments in the healthcare industry, across specialties. That having that comparative data gives a great deal more insight into it than just having Yeah, absolutely.
So
and it's part of the story we need to help, Representative Blumenauer tell about why the value is here in DPC. I think it's really, really key.
Absolutely.
You need
I
a
haven't looked,
separate breakout category. You know, you need to be no longer lumped with a family medicine physician. And so you kind of need your own separation.
Which,
Yeah, we appreciate all being here for sure. A couple of comments and or questions. Currently, about how many family medicine primary care clinicians on that now? One, two, are you currently insuring any DPC positions?
We do have some, I think the number, when Ben sent it over, I want to say it was about 15 DPC positions.
that we know, that we know,
visible. Yeah.
in some ways, yeah.
Yeah, unless you ask.
As far as the total number of family physicians, and I wouldn't have any idea.
We didn't look that up before we came in.
No, I apologize. We can get that.
How many total positions nationally you guys pay? 20-something thousand.
So I think it's closer to 60.
Yeah. So it's probably north of 15-20,000 family medicine.
That would be my guess.
I appreciate that. So a couple comments and thoughts here. So one, as you guys probably know, Bev, and most of the doctors, primary care in general, there's less claims that their doctors have a relationship with their patient versus neurosurgeons.
Sure.
One, and typically a family medicine panel is around 2,000 to 3,000. In DPC, it's around 300 to 800, maybe, right? So there's just a small bucket of people. You think about risk.
Right.
One, and then two, the relationships, I would argue, are even tighter because of the business model that's just about frictionless, where you don't have copays, insurance, and all this headache. And so it'd be interesting to see, like, over time, what that looks like. The challenge is we're still kind of, even though some of us been around for many years, a young organization, give or take, and appreciate the discounts. And then I'm curious, some of us have 1 or 2 docs, some of us have 20 or 30 docs, 50 or 100 doctors. How does it look as you move up on the scale there when it comes to, if we were to come to you and say, hey, we've got 200 clinicians, can you help us out?
At a certain level, the size of the risk, the size of the organization warrants an actual experience rating unto itself. It becomes large enough to have credibility from a claim standpoint unto itself. So that affects the way that we would rate it up or down, right? If it's performing significantly better than expected, then the rates would reflect that, because we can actuarially look at that in a way you can't a smaller organization or a sole physician.
And I'm just curious, as some of us have tail policies, how do you all handle that? So you step away, for example, from Coverus or Copic in the state of Colorado, there's a tail detail that's potentially cost $5 to $15K to do so. So it's kind of challenging. If you retire with Copic,
right,
tail is forgiven.
Same thing. And we would, if you move to ProAssurance, we would bring retroactive coverage over with you. So we would handle any claims that might occur after the transition based on incidents that would have occurred before the transition. So any claim that is already open, it stays with the carrier that it's with. But anything that might be reported later based on something that might have potentially happened before the move would be handled by ProAssurance.
Does that remove the tail?
It removes the need to pay tail to the carrier you're leaving. Yes. So you don't have to worry about a tail if you're transitioning from, say, Coverus to ProAssurance. I'll say this too, and this is just simply because we have more data and information on concierge medicine than we do on direct patient care at this time, and we are in the midst of significantly changing the rating of concierge medicine because of exactly what you're talking about. As we have created more data analytics and looking at the way concierge medicine practices, the significant difference in volume creates a significant difference in risk. So those rates are coming down dramatically. And I would see this probably taking a very similar path as we're able to build that data for ourselves and prove what we intuitively know the case to be.
Yeah. So tell me what dramatic is. So how dramatic?
I will say that I can't remember exactly what it is, but it's the new rating system will be based on patient volume, and I think the discounts off of published rates for a given specialty Because we don't have a concierge medicine specialty, so it's whatever your board of specialty is, and then we come down, is it 60%, I think, at the top end? I think we come off as much as 60%.
So you reduce.
We reduce by, I
as
think
much
it's either
as
50 or,
60%.
don't quote me, it's either like 50 or 60%.
Yeah.
And then it goes down as your patient volume increases.
Yeah.
So if it gets more close to the norm, then it comes down.
So,
But we-
so the more people you have on your panel and the more you mill them through, the more likely you are to get problems, which we all.
And we do know that that's just in general an issue anyway, right? And I'll give you a perfect example in another specialty.
We kind of need to, give the other.
Oh, okay. Oh, we got to go anyway.
One of the things I did want to mention, is that one thing we talked with ProAssurance about is eventually consolidating to a national group policy at a certain premium and volume point. After like maybe a year or two, we'll see what that is. And at that point, potentially a profit sharing endorsement being available for all group members.
There's all kinds of different ways we can slice and dice this.
Great.
And I will be around, they've got a hustle to the airport, but I'll be around after Indigo finishes. So if you have any additional questions, please feel free to.
I appreciate your time. Sorry to rush off. Thank you very much.
Thanks a lot. Yeah. These guys are. I'll bring back some food.
It's food time.